Well, thank you and good morning. I'm Scott Lucia. I'm a professor and vice chair of anatomic pathology at the University of Colorado School of Medicine. It's an honor to be able to do the first talk on focal therapy this morning and give my perspective, the pathologist perspective, on focal therapy. So today, what I want to do is identify the pathologic features that are important for selecting patients for focal therapy and discuss the limitations of standard trust biopsies for getting there. Discuss the advantage of transperineal template-guided mapping biopsies, or what we call TTMP, and MRI targeted biopsy for the detection and grading of prostate cancer compared with truss, and discuss how prostate grade on both of these different techniques compare with prostatectomy results. By way of full disclosure, I am a shareholder of 3D Biopsy, a company that makes materials for use for focal therapy. However, I will not be discussing any of those materials for this talk. So when we think about the best candidates for targeted focal therapy, you kind of use this figure here with green being good and red being poor. It encompasses a number of pathologic features. For instance, grade should be reasonably low grade, 3.3, 3.4, although higher grades can be done in certain circumstances. In general, Gleason grade 8 through 10 is a poor candidate for focal therapy. Tumor volume should be low. It's best that if it's unilateral, but bilateral tumor can also be managed this way, as we'll see. Focality, it's best to be unifocal, but again, multifocal tumors can be handled in certain circumstances, and the stage should be organ confined. But there are other factors that go into picking patients for focal therapy. One is the therapeutic modality you're going to use. So is it going to be cryotherapy, HIFU, or are you going to use electroporation? Different techniques may ask for different types of candidates. And physician philosophy. Are you looking for cancer cure, meaning I want to eradicate every cell that's cancerous in the prostate? Or are we looking more for cancer control of the index lesion or the most aggressive lesion? Or do you feel that your philosophy is that targeted therapy should be an alternative to active surveillance, or as an alternative to radical therapy that's going to change the patients that you look at? If you're looking at it as an alternative to active surveillance, 3+3 cancers are certainly targets for focal therapy. Or if you're looking for an alternative to radical therapy, you might consider only 3+4 or 4+3 individuals. And there are many different focal ablation strategies. There's the so-called site-specific, very targeted approach, quarter gland approach, the hemigland approach, where half of the prostate is targeted, or even an extended approach, which may enable you to get more bilateral lesions. Notice that in every one of these diagrams here, there's a little green dot over here. Those green dots represent small, low-grade 3+3 or grade group 1 tumors out of the field for targeted therapy, suggesting that this would be tolerated since these would fit under the auspices of active surveillance from this point on. So what about using truss biopsies to identify candidates for focal therapy? The problem is that cancer sampling with random systematic biopsies is a function of the tumor volume to prostate volume. So a large tumor in a small prostate is easy to hit with a needle, whereas a small tumor in a large prostate, not so much. Similarly, the sampling of the high-grade component of any tumor is a function of the volume of that high-grade component with prostate volume. So a small component of high grade may be missed. So the biopsy may not sample the highest grade or even the index lesion. The anterior prostate is relatively undersampled with this methodology. Now, biopsy is a poor staging tool and is completely inadequate for precise tumor location. And this can be reflected in the SEER data based almost on 26,000 patients. And you look at their biopsy Gleason score here. And if we look at 3.3s, for instance, and their rate of pathologic Gleason upgrading, if these patients went on to prostatectomy, you can see anywhere from 40 to 60% of them are upgraded. And not only that, pathologically advanced disease can be seen in 15 to 40% of patients with biopsy Gleason scores of 3.3. So clearly, truss-guided biopsies aren't a good alternative for picking candidates for focal therapy. And the concerns are thus: how can we accurately assess tumor grade and aggressiveness and tumor extent, including multifocality, volume, and location, using biopsy techniques? And once the cancer location is known, can we precisely deliver target back to the therapy back to the target? Well, there are two possibilities here. Potential solutions include you can increase sampling. And in this, I would say precise sampling using the transperineal template guided mapping biopsy technique, which uses a brachytherapy template to target biopsies, if you will. This is kind of like playing a big game of Battleship with your prostate. And you can see that we biopsy the prostate left, right, and down and in every 5 millimeters to really sample the entire prostate. Whereas a truss biopsy, you're shooting a few biopsies in the hopes that you'll hit the target. With a transperineal mapping biopsy, you essentially saturate the grid, getting hits on all the targets that you will. And we have shown through simulations that this is highly effective. This is a 3-dimensional reconstruction model of an actual prostatectomy specimen here with tumor foci within it. And we did a simulated biopsy technique every 5 millimeters and showed that by doing this, you can get very, very accurate assessment of all the tumors in here, including the small tumor up here, and with a little bit of model error for tumor volume when you reverse reconstruct these. But the theoretical volume threshold is very, very low, on the order of 0.04 cubic centimeters, which would be smaller than the head of an eraser. You can then use the reverse reconstruction technique using the outline of the prostate as your guide from ultrasound, and then fuse this with the ultrasound to get localization so that you can go back and treat this particular area. So very effective for focal therapy targeting. Perhaps the best data comparing how TTMP works over truss comes from the PROMIS trial, a UK trial, multi-center trial out of the UK, in which 576 patients got all modalities. They got TTMP, they got a systemic truss biopsy, and they got multiparametric MRI. And you can see that in every instance, the transperineal approach, the mapping biopsy, outperformed truss biopsy for the detection of cancer through all Likert scores here, including those that would be considered MRI negative down here in the Likert 1 and 2 region here. And this is for clinically significant prostate cancer. The insignificant cancers were excluded. And their definition of clinically significant is 4+3 or grade group 3 or higher tumors, or tumor greater than 6 millimeters. So that's overall detection. Now, how does it compare with prostatectomy for accuracy of pathologic grade? And here's a study out of Australia looking at 431 prostatectomy specimens, retrospectively looking at how they were diagnosed, either by truss biopsy or by transperineal mapping biopsy. And you can see the number of cores here. Even their truss biopsies tended to have more cores than we see in the United States. But you can also see that in their data, they showed that over 22% of their tumors diagnosed by truss biopsy were upgraded from Gleason score 6 or below to Gleason score 7 or above. In other words, grade group 1 to grade group 2 or higher, versus only 14% diagnosed by mapping biopsy, and this reached clinical significance. We can also look at our data in our institution. We've looked at this in 215 patients who had both a truss-guided biopsy and a template-guided mapping biopsy. And you can see what happened here. When you look at the grade group phenomenon here, 40% of our cases were upgraded from truss biopsy to mapping biopsy, particularly in the Gleason 6 range here. You can see going from 155 to 98. And you can see that there was a grade shift towards higher grade tumors, including a Gleason 9 tumor that was completely missed by truss biopsy. In addition, over 45% of our tumors were upstaged by this, going from unilateral to bilateral tumor. When comparison with the prostatectomy specimens, we had 32 patients who had a subsequent prostatectomy after having both a transperineal mapping biopsy and a truss biopsy. And you can see how it compared with the gold standard, the prostatectomy grade. Almost 2/3 of the transrectal truss biopsies were upgraded, although none were downgraded, whereas only 16% of the TTMBs were upgraded, although there was some downgrading in that group. And here's how it looks, comparing the Gleason score over on this side and the biopsy score by different modality across the top. Here'd be the concordance diagram right here. This diagonal group here would be our concordance group, showing the concordance with truss biopsy was only about 32%, where it was 2/3 with the TTMB group. In the yellow would be areas of upgrading. The green would be the downgraded tumors here. And you can see most of the upgrading occurred from 6 going to 7 or even higher. In fact, bring your attention here to this group that was negative by truss biopsy. And there were high-grade tumors in here, including 2 Gleason 9 tumors in this group here. And if we look here, very little upgrading. Again, the most prevalent upgrading occurred from Gleason 6 to Gleason 7. And if you look at the downgrading that occurred here, most of it was Gleason grade, pattern 4, either being downgraded because there was some 3 in the final specimen or more. So that's where the downgrading tends to occur. Another group, this is the Memorial Sloan Kettering group, has actually broken this down a little farther. They've looked at location of biopsy, of the template biopsy in comparison with where the tumors were located within the prostate. And these are all tumors within whole mount sections of the prostatectomy specimen. You can see their sensitivity was overall about 86 with a specificity of 83%, a little lower than they expected. But when they broke it down into region, it's clear that in the posterior portion, the posterior part of the gland, their accuracy is very, very good. The problem comes up when you get into the anterior regions. They tend to be undersampled here, and that's where things break down. So tumors in the anterior region still can be a problem with TTMB, although it's less of a problem than it is with truss biopsy. So that's one possible solution. And the other possible solution to identifying candidates would be to add imaging with targeted biopsies here. And here we're talking about multiparametric MRI. Perhaps the best way to begin this is to look at the Precision trial. This was a multi-institutional prospective clinical trial published in the New England Journal of Medicine, where they randomized men into either an MRI targeted biopsy group or a standard truss biopsy group here. And you can see that about 28% of this group had a negative result on MRI, therefore there wasn't a targeted biopsy per se. But despite of that, clinically significant prostate cancer, which was defined as Gleason 7 or above, was found in 38% of the MRI targeted biopsy group versus only 26% of the standard biopsy group, and this was significant. And you can see the stratification of grades here. The MRI targeted group tended to have higher Gleason scores than did the standard biopsy group. And they looked at the primary outcome, and depending on how you want to look at the data, either an intention to treat analysis, which includes all randomized patients, or a subgroup of the randomized patients, as shown here. No matter how you define it, the MRI targeted biopsy outperformed truss biopsy for the detection of significant prostate cancer. Now, again, we need to try to compare grade results with the prostatectomies. So this is a study, another multi-institutional study, this one out of Europe, that looked at 443 patients who had both a systemic 12-core biopsy plus targeted biopsy, MRI targeted biopsy. And what you see here is the rate of upgrading that occurred when compared with the final gold standard prostatectomy grade. Systematic biopsy had a greater than 40% upgrading rate, which would be in the gray area here, which was less in the targeted group, but the combination performed better for reducing upgrading, having more concordance, but also having a slightly increased rate of downgrading when compared to the final prostatectomy result. And this was true for overall ISUP grade, or if you confine it to just ISUP grade 2 or above, grade 1's going to grade 2 or above, or in biopsy naive patients. In every case, the combination of systematic plus targeted biopsy was superior than either of the modalities alone. Another excellent study coming out of the NCI that was also published in the New England Journal of Medicine looked at a high number of patients, over 2,100 patients, that got both a targeted biopsy with at least 2 cores per lesion and standard 12-core sextant biopsy. And you can see again that the combination of the two types of biopsies together outperformed either one alone, particularly for higher grade disease. But it's more interesting looking at the upgrading rate. So they could compare it with about 400 patients who had prostatectomies as the gold standard. And again, the combination resulted in less overall upgrading, only 14% were upgraded. And if you break this down to upgrading to grade group 2 or higher, or even grade group 3 or higher, it dropped even less. These would be significant upgrades here, or quite small when combined compared to targeted or systematic alone. Another interesting way of looking at this is done by a couple of different groups. This is a group out of Korea that asked the question a little differently. They retrospectively looked at a number of radical prostatectomy specimens, over 800, and defined them as being either eligible in retrospect for targeted focal therapy or ineligible. Now, eligibility for them was defined as having a Gleason score 3+4 or less and unilateral tumor. So that's the limit of their eligibility requirements. And then they went back and looked at their prostate biopsy plus MRI results to decide if those results would have suggested those patients would have been eligible. And you can see here that of 154 patients that they thought were eligible based on the prostatectomy for targeted focal therapy, 112 of them were identified as such on MRI and systematic biopsy combined for a sensitivity of almost 73%. The problem here lies in this row right here, the positive predictive value, because of the total number that were thought to be eligible by prostate biopsy and MRI was 185, and yet 73 of these were found to be ineligible either because they had higher grade tumor or because they had bilateral tumors. So the positive predictive value here was only a little over 60%. And if you look at where the problem lies, it wasn't in the lobe that was positive. In the biopsy positive arm, there was pretty good concordance between the radical prostatectomy and the targeted biopsy. The problem was in the negative lobe. This was the lobe that had no cancer on a biopsy, so the systemic biopsy was negative and did not have a PIRADS 3 or higher lesion on multiparametric MRI. And in that group, the concordance was only 30%. There was an almost 70% false negative rate here. And of those, almost 40% of them were considered significant cancers, and many of them had higher Gleason grades here. This is another group. This is out of UCLA, Lenny Mark's group. They looked at 454 men with PIRADS 3 or greater lesions on multiparametric MRI. And then they did targeted biopsies and again combined it with a 12-core systematic biopsy. And what they defined were any of these three scenarios would be eligible for targeted focal therapy. Either the tumor was limited to just the targeted lesion, or had positive biopsies with clinically significant cancer outside of the target, but unilateral, on the ipsilateral side as the target, suggesting that a hemiablative technique could cover all of this, or had a significant lesion for the targeted lesion and could have contralateral tumor if it was Gleason grade 3+3 or grade group 1 in small amounts. In other words, their ineligibility criteria down here on the left was that it was bilateral significant tumor, which was defined as 4+3 or higher, or having less than 4 millimeters of 3-3 cancers. If that's all they had, they were considered ineligible because they figured these were better candidates for active surveillance. So again, more of a cancer control paradigm here for this group. Here's a figure that comes right from their paper. Although they found almost 39% eligible for targeted focal therapy based on these features up here, the location of the positive biopsy, using either a site-specific quadrant or hemigland approach, they presented these data in their figure here. And if you look here, what they've done here is fused their MR visible lesion in green with their actual pathologic whole mount lesion in red here. And in almost every instance, you see that the red lesion, the pathological lesion, is bigger than the target itself. One, indicating that you need to extend your biopsies beyond the target to really define these areas. But two, it also implies that the only way to really be comfortable with this kind of approach is to do a hemigland technique for ablative therapy. Now, how do these combine with each other? There's a few papers on these. These two I'd like to highlight here. If you look at how multiparametric MRI compared with template-guided mapping biopsies, this is a study out of Europe looking at 124 patients who had a negative MRI, so no target to be able to biopsy, and then followed by having TTMP. And you can see over 25% of them had clinically significant cancer defined as 3-4 above detected. This is another one using TTMP, the Barzell's technique, a little different technique, divides the prostate into a number of zones and does multiple biopsies in each zone. They identified tumor in 36% of men with a prior negative trust biopsy, nothing to target here. And of those, 70% of them were significant. 30% of them were Gleason score 7 or above, and most of them were anterior tumors. And in a recent meta-analysis looking at about 43 studies, compared multiparametric MRI with or without targeted biopsy and TTMP, and the overall negative predictive value with all of these studies combined in the meta-analysis was 92%, meaning that about 8% of tumors, significant tumors, grade group 2 or above, were missed by MRI targeted biopsy as compared to TTMP. So in conclusion, pathologic features are important for appropriate patient management. They include grade, volume, and location of the tumors. Traditional truss-guided biopsies schemes are inadequate. Transperineal mapping biopsies and MRI-guided targeted biopsies offer improved pathological accuracy, with the highest level of accuracy being seen in TTMP. But combined systematic biopsy plus MRI targeted biopsy is useful to determining eligibility for focal therapy. And although it is useful, it may underestimate tumor burden and focality. And hopefully we'll see improvement as we move from 3T to 7T technology. And with that, I'd like to conclude. Thank you very much.